Hi, my name is Karen Evans, and I'm enrolled in the RN to BSN program here at UMass Dartmouth. My scholarly research project investigated the problem of heart failure, which is one of the major public health problems with a 1 to 2% prevalence. Patient outcomes show a very high 75% mortality rate, and my purpose was to determine if cardiac rehabilitation for heart failure patients, either HFpEF or HFrEF, would improve patient outcomes. Heart failure with preserved ejection fraction can be described as an ejection fraction measured by echocardiogram of greater than 40%, while heart failure with reduced ejection fraction typically is less than 40%. This can vary slightly depending on institution guidelines. The lifetime heart failure risk for adults over 55 is 33% for men and 28% for women. Patients experience reductions in exercise capacity, quality of life, and performance of ADLs. Participation in cardiac rehab is less than 10%, even though results showed that exercise training relieves heart failure symptoms and improves exercise capacity and quality of life. It further reduces the disability and hospitalization rates and should be standard of care for heart failure treatment, both for heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. My research question was, does participation in cardiac rehabilitation versus usual medical care without cardiac rehabilitation improve patient outcomes in patients diagnosed with heart failure? Again, either reduced ejection fraction HFrEF or preserved ejection fraction HFpEF. In reviewing the evidence in the literature related to my research question, these were the key components identified: exercise capacity and cardiovascular symptoms, body mass index, waist circumference, blood pressure, glycemic control, lipid levels, tobacco use, and anxiety and depression. The secondary prevention goals achieved through cardiac rehab interventions led to improved physical fitness, functional capacity, quality of life, reduced CV events, hospitalizations, mortality, adverse events, and cost and resource use for organizations. The evidence I looked at was 2 meta-analysis studies and a systematic review, as well as 2 clinical trials looking at cardiac rehab in heart failure patients. The meta-analysis studies looked at 57 clinical trials and a total of about 10,000 patients, mostly with HFrEF, but there were some HFpEF patients. Results also included 2 independent clinical trials. All the data supported cardiac rehab as a method to improve quality of life, exercise capacity, and reduce hospitalizations and readmissions. Interestingly, both home and center-based cardiac rehabilitation models demonstrated cardiac rehabilitation as improving quality of life and exercise capacity, both leading to improved outcomes in heart failure patients. The implications for practice include that cardiac rehab should consist of a personalized program with a holistic approach and be easily accessible for the patient. Cardiac rehab options include home-based, center-based, or alternatives like electronic device or mobile technology-based models. Cardiac rehab should be valued as an integrated part of an overall management program for all heart failure patients, as you can see by improvements in quality of life, reduced hospitalizations and readmissions, and improvement in exercise and functional capacity for our patients. Automatic referral is the most effective method for increasing cardiac rehab participation. A nurse-led follow-up program is recommended and implemented as part of treatment for heart failure. Findings of all my research showed no significance in initial all-cause mortality or heart failure mortality, a reduction in all-cause hospital admissions and heart failure-related admissions, and that was at 12 months. A significant improvement was found in patient-reported quality of life and a reduction in the risks of rehospitalization, as well as improvements in fitness evidenced by the VO2 max score improvements. There was no difference in improvements in the conventional versus the mobile or home-based cardiac rehabilitation. The improvements were equal. Some of the limitations I found were continued low participation rates and high dropout rates after enrollment, despite improvements in physical fitness, functional capacity, and patient-reported quality of life. The limitations also included a lack of diversity in study populations, including women and people with HFpEF. Further trials are needed looking at the feasibility and cost to facilities of implementing cardiac rehabilitations, and interventions would be established to enhance the long-term maintenance of the exercise trainings. References for my research are listed below. I've included my contact information below, and please feel free to contact me with any questions or comments. And I want to thank you for allowing me to present my research.